So, welcome back, everyone, to the Department of Population Health Sciences podcast. I am delighted today that we've got Professor David Forbes with us, and we're also joined by Dan Lately, my co-host, shall we say, in this podcast for this week. I'll introduce David shortly, but Dan is a lecturer in digital health sciences with a focus very similar to David's. And to introduce David, who I'll then hand over to shortly. So Professor David Forbes is the academic director at Maudsley Health, UAE, and based in Abu Dhabi. David is also a professor in the Department of Psychiatry at the University of Melbourne. David is a clinical psychologist with extensive experience in the assessment and treatment of mental health problems following trauma, and he's worked in both acute crisis and continuing care settings across the community mental health system. David is an international expert in PTSD, so post-traumatic stress disorder, traumatic stress, military, emergency, and disaster mental health. He's also an expert in the relationship between trauma and problematic anger, and is deeply committed to initiatives to improve outcomes for people impacted by adverse events and trauma. So, David, I know you're going to introduce yourself a little bit now. Do mention anything that I've potentially forgotten. Otherwise, welcome. Thank you so much for being with us. Really excited to hear from you, and also excited that we've got Dan with us as well to bring that additional expertise. David, over to you. Thank you so much again.
Look, thank you very much, Martin and Dan, and for the opportunity to talk to you and all of the colleagues across King's. So look, perhaps if I do start with just a little bit more detail, a little bit about my background and particularly my journey from kind of the start of working as a clinical psychologist through to kind of how that journey evolved over time. And then a little bit more about what my research interests are of late and where things are at the moment. And potentially also there's some really nice points of intersection around collaboration between the things that we can do together over the course of time as well. So in terms of me, thank you for that background, Martin, but just to kind of reinforce this, I'm a clinical psychologist by training. I'm currently sitting as the academic director of Maudsley Health in the UAE, where I've been for the past 12 months. And Maudsley Health, of course, is an affiliate with Maudsley Slam in London. So there's that strong relationship. I also do hold an honorary professorial fellowship from the Department of Psychiatry, Melbourne University, and that sits within the Faculty of Medicine, Dentistry and Health Science. So that includes all of the medical departments, but also psychology, psychiatry, public health, and also mental health evaluation and nursing. So it's a very diverse faculty, which provides a lot of opportunity for interdisciplinary and collaboration, cooperation, and potentially also kind of across a broad range of themes. So a little bit about my journey. I started working as a clinical psychologist initially in public mental health services in Melbourne, Australia, which are very focused on severe mental illness. So for people with common high prevalence mental health problems, they're unlikely to be seen in public mental health services. So it really is around the severe mental illness side. And my work was in hospital settings, in community settings, both in terms of general secondary care, but also particularly outreach care for those with severe, chronic and disabling mental health problems who are also experiencing homelessness. So out on the streets supporting those with severe psychiatric disability. And also included a period of time in acute psychiatric crisis care, responding to people with crises in the community with kind of acute needs and difficulties. So after a number of years in the state mental health system, I was invited to move across to the state psychological trauma service. And that was an area of interest of mine going back. I did my master's thesis in the area of trauma and psychological interventions for trauma. So when the invitation came to join the state-based psychological trauma service, I was very excited about that. And at that stage the service was more focused on military, veteran and first responder services. And this is speaking to my age a little bit, but in those days as well, we were really still in the phase nationally and internationally of working out what best practice treatment for PTSD actually looked like. It was very much in those early stages. And that was a lot of the work of our clinic within the hospital really, which was to develop and refine expert specialist trauma services for those at the acute end, particularly veteran, military and first responders. And having worked at that state centre for a little while, I was then invited to join as deputy director Australia's National Centre for Trauma-Related Mental Health under the wonderful leadership at the time of Professor Mark Creamer. And the significance of that was that the National Centre had oversight for the development of the programs like the one I was on in Victoria. They had a responsibility for the oversight and development of those nationally. So their support in developing guidelines for what treatment looked like, what the program content looked like, what the clinical competencies were that the clinicians required, and also embedding in that outcome evaluation. So being able to ensure that outcomes, clinical measure outcomes were embedded in these programs as well. So that National Centre had a really unique lens. And the National Centre also at the time had a very strong service development role, which was kind of annual visits to each of the programs, discussing what each of the programs were doing in terms of content and approaches, identifying what kinds of clinical presentations were proving difficult to engage or treat, and then also to kind of review how the outcome data was progressing and try and understand where things were strong and where things could be developed further. Within that role also, there was a chance to lead what became a kind of an annual meeting of all the programs across the country, bring them all together and talk about what the outcomes were showing, not centre by centre, but overall, have a look at what the trends were in national and international evidence-based literature, and for programs to also showcase where they were making some innovations that we felt that could be worthwhile having been presented across to other programs so we would learn from each other. I guess the words we use for that now are community of practice, but we were doing that before community practice became a well-known and commonly referenced term. And that was really one of the things that was, very powerful about the process. And the reason I'm going into a fair bit of detail around this period was it was absolutely pivotal for me in terms of my professional career development. I went in that role, starting off in that deputy director role, I really went from thinking about intervention specificity or program specificity through to starting to think about things at national scale levels. What are some of the things we need to think about when we're trying to identify what's needed across the country? Where are the gaps? Where are the areas of development? What are the mechanisms and barriers to implementation for programs at national level? And how can we uplift what might be there in a way that actually maximises uptake and engagement? So it really was very pivotal in my thinking, kind of moving to kind of systemic thinking rather than program thinking. So I was deputy director for about 12 years and then became the professor director for the subsequent 13 years. So from 2011 to 2024, up until March of last year. I was the professor director, and at the end of March 2024 moved across here to the UAE, Maudsley Health, really feeling like the centre had achieved an enormous amount in that time, and thinking about invited to come and give a presentation here in the UAE, and really being struck by the potential for development of services and service systems as the country was becoming increasingly mental health conscious. There seemed to be a great opportunity really for collaborations and development in terms of expanding what the mental health landscape and what mental health services might look like. In terms of the time, what was effectively 25 years at the Australian Centre, we'd gone a long way to developing that centre from that very specific PTSD programs for veterans and first responders role to thinking about and having as our mandate anyone impacted by trauma across the country, and not PTSD, but any shape and form in terms of impacts that trauma might have. And thinking about that from prevention all the way through to mitigation on an individual level and on a system level. And through that, building out 4 streams of work within the centre, one around research, one around training, one around policy and service development, advice and support, and one about developing our own clinical services. What was very important to me as the director and to us as a leadership team in an organisation was also trying to ensure that we were able to promote integration across those 4 streams. So conducting research to address knowledge gaps so that we could use those to build gaps in mental health services. Providing training specifically around what were the new innovations occurring and what training did practitioners, providers and organisational leaders, where the organisation was the place affected by an event, what kind of training did those providers or professionals need to be able to carry out what needed to be carried out in terms of what the evidence was dictating was required to be done, particularly after significant events, and generating and trialling new service models to address unmet need, and advancing existing care, both in terms of new interventions as well as models. So trying to identify what are some models we need to think about we would then be able to test out within our services or in collaboration with the services out in the field. And then trying to see where does that fit with us being able to take all of the above and provide that as advice to government, state government, federal government or agencies in relation to what does all this say about what services need to be developed, what our policy advice looks like, what our community and public messaging advice needs to look like to support that initiative, and trying to make sure that as best as possible that all interconnected rather than taking a siloed approach to each one of those streams. Through all of that, while there was a key role in terms of service system for trauma impacted people across Australia, really mindful personally, professionally, but also from a field about the importance of developing national and international initiatives that focused on collaboration and support. What kind of national initiatives would be able to take us as a field to the next level? So the first part, and this was really part of setting the standard within Australia, was leading Australia's inaugural guidelines for the prevention and treatment of post-traumatic stress disorder. And that was through our NHMRC, which is the equivalent of the UK NICE. So we developed and I led the inaugural kind of NHMRC guidelines in Australia for the prevention and treatment of PTSD. And that then became an evidence-based high quality standard for everything else that we would do. That became really our point of reference for what we did, what we're advising others to do, and guiding us about what the gaps were that we needed to address. Because as we know, the evidence base only speaks to a certain amount, and from there on we're really guided by expert opinion. So the guidelines also identified for us where we needed to build out those gaps so we had evidence where we just currently had consensus. The other part is in our thinking, or in my thinking, also development of key national and international partnerships with like-minded centres. So a critical partner through all of this time was, of course, King's College. And so developing very strong collegiate relationships with our colleagues from King's College, particularly the King's Centre for Military Health Research. And together we developed an MOU between our centre at Phoenix, Australia, the National Centre for Australia, and KCMHR from King's College as well. And so forming that MOU really to establish the solidity of that relationship. On the international side more broadly, also thinking about what approaches would be helpful in terms of being able to address big areas of unmet need that were hard to address at an organisational level or even at a single partnership organisational level. What issues really needed international network collaborations or collective collaboratives really to be able to move the field forward. One of those at the time was our gap in evidence base around early intervention models for adjustment problems in the aftermath of trauma and disaster on writ large. We had good treatments for treatment of PTSD, but in terms of what low intensity or trauma focused or disaster focused low intensity interventions looked like, there was a gap. So one of the things we did was to develop a national international collaborative, and we did so in collaboration with the Prince's Trust, and co-facilitated 2 meetings with His Royal Highness at the time, or parts of those meetings that were co-facilitated together. One was focusing on interventions for adults, and that was done during his visit to Australia, His Royal Highness's visit to Australia, and the second was focused on child and adolescent responses to trauma and disaster, which were conducted at Dumfries House, his residence there. So really thinking, and there the representation was 10 to 15 nation representation from those across the field of trauma and disaster. Another example in thinking about collective approaches and collaborative approaches was taking the area of military and veteran mental health. And in that context, had always been struck by the fact that across our Five Eyes colleagues, ourselves in Australia, US, UK, Canada and New Zealand, there are a range of centres like us who are one step removed from government, providing independent advice. But there was no obvious mechanism for us to communicate together in a fairly consistent way. We were able to inform each other of advances, be able to adopt challenges together in terms of addressing issues. So together with my colleague, Professor David Pedler, who led our Canadian counterpart, we formed what became known as the Five Eyes Network of Research and Innovation. So it was across the Five Eyes nations where we would meet annually and discuss the issues that were close to mind for all of us and we felt were important in what the advice was that we were wishing to give to our governments, or in response to requests from government. How can we better support our respective governments also by sharing our knowledge and advice together, minimising duplication, but also being able to, there's no doubt that the whole is greater than the sum of its parts, and be able to think and identify key issues that we perhaps none of us may have had the opportunity to do alone. And of course, from the UK perspective, King's College and Combat Stress were core partners in that Five Eyes collaborative. In terms of the trauma field, more broadly, the peak scientific body is the International Trauma Society, International Society for Traumatic Stress Studies. So there I've had a role as the Deputy Chair of the Clinical Guidelines for the Prevention and Treatment of PTSD in the previous iteration of the guidelines, and I'm the current Chair of the forthcoming next iteration of the Clinical Practice Guidelines. And really being able to ensure that we maintain good connectivity across the field as we start to think about what are the issues that the next iteration of guidelines has to deal with. And really important is having a really strong awareness and connectivity with what the NICE guidelines are saying, what the Australian guidelines are saying, what the WHO guidelines are saying, Veterans Affairs and Department of Defence in the UK, in the US. So really ensuring that the international society is able to move as an international society, incorporate the best of what's happening on national levels around the world. And kind of really enjoying that lens as well. So across disaster, across trauma more broadly, and also then across veteran and military, kind of awareness of what these key collaborative initiatives needed to be that can support specific initiatives locally, as well as specific collaborations internationally. And the last really is around my work on NATO panels. So at the invitation of Professor Dominic Murphy from King's College, from KCMHR, together with Professor Albert Geuze from the Netherlands, sitting on the previous and current panels around personalised medicine and mental health outcomes to support collaborations around the NATO space. In terms of my focus of my own research, kind of throughout that time, obviously over the course of my career, my research has been wide and varied. But just to point out perhaps a few areas of particular focus. One is in the area of disaster mental health. And it really started after our Black Saturday bushfires in 7th of February 2009. And that was Australia's most fatal natural disaster. And I was involved at the time in developing service models and training for those who were impacted in the areas, for training of providers in the area. But one great initiative started by Melbourne University Public Health and led by Professor Lisa Gibbs was development of a longitudinal study looking at the outcomes of Black Saturday. And they were being part of a really multidisciplinary, long-standing longitudinal study under the leadership of Professor Lisa Gibbs, looking at examining trajectories of recovery, what are some of the factors that result in emergence of new problems, what are the factors that result in early recovery, what are the social factors, psychological factors, community factors, familial factors that intersect with what those trajectories look like. And on the back of that, be able to provide, not only build the evidence base out, but be able to provide advice to our state government, to our federal government about what does this mean around service support, in the short term, medium term and long term, and outside of the mental health space specifically, because it was really seeking to examine and evaluate the intersection across mental health and wellbeing, but within the diversity of experience in government services and community services. What does this mean about the connectivity around some of those services as well? And what that led to was myself and others having a bit of a think about the degree to which services tend to be siloed in the context of these events. There may well be a lot of services provided, but everyone provides what it is they're designated to provide. And there's a lot of gaps and cracks that exist between those services for survivors of disaster, survivors of trauma more broadly. And that led myself and Professor Neil Greenberg from King's College as well, together with kind of a range of colleagues, to lead a brief commentary piece in Lancet Psychiatry. Really was about focusing on integration of guidance in the aftermath of mass disaster. And really a big focus on how to ensure connectivity to get better outcomes for those impacted, how to make sure that the insurance guidance, the clinical guidance, the government directory guidance weren't working at cross purposes, to ensuring that people not only got well sooner, but was prioritising return to role, function, and doing all of those things that sometimes we get a bit lost when we focus just on symptomatology. So very much a multidisciplinary, multi-service approach to integration through that Lancet Psychiatry piece. The second area of personal interest, and as was mentioned by Martin in the introduction, is the area of problematic anger after trauma and disaster. And anger is ubiquitous across disaster impacted communities and for individuals who are trauma impacted. But interestingly, there's very little attention to anger in literature, in clinical training, in services. It tends largely to be focused on anxiety, depression, PTSD, other states, but very little focused on anger. In some respects, anger is kind of seen as a bit of an epiphenomenon of all of these other problems rather than addressed as a problem in its own right. Yet we know that severe anger causes enormous distress to the individual and has major impacts on their quality of life, but also the lives of those around them, impacts on the family, impacts on their capacity to maintain and hold down work, impacts on their capacity to maintain social relationships. So a big focus for me was trying to then remediate, one, can we learn more about the prevalence of problematic anger in the aftermath of trauma and disaster? What do the impacts look like at a scientific level, individually and across their landscape of function? And what does this mean for what intervention needs to look like? And as much as anything, really try and make sure that anger was starting to get national and international attention. So within that 4 or 5 different commentary pieces to various journals or editorial pieces, really trying to make sure that anger got on the agenda. And the position really was that this has been the neglected emotion in the affect family for a really long time. One of the other issues that came out for us in our work, and kind of particular mention here of Dr. Olivia Metcalf, and she and I have an NHMRC Ideas grant, kind of looking at a just-in-time intervention for anger in terms of a just-in-time app. But one of the things that came out in terms of us doing our background work was the degree to which there was still a significant gender divide in relation to the recognition of anger and how it was supported. So one is knowing that women were more likely to be experiencing increases in the experience of aggression and violence, but also in terms of their own anger, the degree to which their own anger was often minimised or invalidated, or where they expressed it and it was recognised, tend to be pathologised. So on the back of what was coming out to us as a massive gap in terms of the recognition and validation of anger in women, kind of we wrote and had published about a month ago a piece in editorial piece in JAMA Psychiatry, really trying to put on the agenda recognition about women's anger after trauma and the need for that to be treated in a much more substantive way. Another area of focus has really been advancing military and veteran and first responder mental health and wellbeing, and probably the area for which my work's most known. So I probably won't go into any details on those, recognising that that's one that would be a workshop for a day rather than a quick talk. But one piece of research I wanted to flag was a piece of work we did as part of a NHMRC partnership grant with our Veterans Affairs and Department of Defence that I did co-led together with Associate Professor Lisa Dell and Dr. Elisa Sabissa from Melbourne University, Phoenix, Australia. And that was looking at testing kind of intensive models of treatment for PTSD in veterans and current military members. And the reasons for that were there were so many reasons why current and ex-serving military weren't accessing PTSD treatments, one of which was just how spaced out they were, once weekly, and so many things could interfere. And in a typical veteran way, also having a desire to roll up their sleeves and really get it. If I'm going to do this, I want to set aside the time and do this properly. So very important for us was to identify and test what an intensive model might look like. Weekly for 10 days, 10 days over 2 weeks versus weekly over the course of 10 weeks. Perhaps a point to mention in this was Australia's largest PTSD treatment trial. And what we were trying to also do was to optimise the ecological validity of the trial. And this is where a lot of my interest is also moving now, is how do we ensure that the science we're doing is as ecologically valid as possible? So how do we make sure that the services that we're trialling these treatments are, not only is it a well-controlled trial, randomised controlled non-inferiority trial, but ensuring that we've got small centres, big centres, that the clinicians working in the trial are the clinicians from those centres themselves. The patients in the trial are the patients from those centres themselves, minimising the amount of advertising outside of the existing clinical network, to try and ensure that the services that were provided, the treatment that was provided through the trial was as close to exactly what it could be for the therapists and for the patients who were part of that service system already. And also through that process, training up enough of clinicians so that if this trial was successful, which it turned out to be, we had a pre-existing trained workforce ready to take up and implement these treatments in current serving and ex-serving military environments. And kind of with some pride, this project was just awarded one of the 10 best for the year by the NHMRC. The only mental health trial to be nominated or to be awarded that over the course of the year. And I suspect it may less be about the size of the trial or the findings, but as much as together with that, the systematic focus on the ecological validity of the trial, so that this was genuinely seen as an attempt to shift the dial in terms of making as proximal as possible the new finding subsequent to its uptake in the community as one of a genuine service offering. The last piece of research perhaps to mention is the area of digital interventions, and personally it's something that's newer for me, and my work in this space has been led by my colleague Dr. Olivia Metcalf, but we are developing a just-in-time app for anger using passive data, wearables and passive data, things that can aid, particularly with the high risk attached to anger, that can aid intervention just in time in that moment, and using data from the passive data from the wearables to be able to inform and provide messaging to that individual about what things they might need to do to de-escalate risk. So on that, I've probably gone on long enough. So thank you, and I hand over back to my hosts.
And David, thank you so much. A fantastic overview. Because of course, one of the things that we're trying to achieve through this podcast is to connect people together. So you've given a huge amount of hooks there for people to see something that they're interested in. And I'll say this again, I think at the end, if I remember, but I trust you're happy for people to reach out to you. If something you've said in the last 30 or so minutes, resonates with them and they want to work more with you on that, you're happy for people to reach out with you and talk more?
That would be terrific, yes.
Superb, absolutely brilliant. And so I do have a question, but it's slightly, I don't know what the word is, deep. So I might wait and hold it back, and I might hand over to my co-host Dan, who might have some slightly less quote unquote deep questions, if I'm allowed to call them that, just to kind of warm things up, shall we say. Dan, you're okay to jump in?
Absolutely. Thanks, Martin. David, thank you so much for that very brief overview of your career today. It's incredibly impressive. And when I was preparing for this kind of podcast, I did have a little look, and your first paper on PTSD was published in 1993. So you've been working in the trauma space area for many years, more so than before it was recognized, when we think about, especially in the military context, when we think about PTSD and actually its recognition. That only came much later on. The stigma and barriers in the military context overcome. So you like with many of your topics, you've been doing them before they were cool, which is great. I was going to ask a few questions, but I'll probably jump around a little bit. But I found the one your current interest on your new interest on anger, but the intersection with digital technology, because that's the area that I'm quite interested in. And when you talk about validity, so we've got digital technology, wearables, and then we're thinking about how do we undertake ecologically robust studies to assess the validity. In your mind, how are you balancing the excitement of what wearable and digital and AI is going to bring versus the need for robust trials, privacy, equity of access, which are all big topics, right? That is a deep question in itself, but what are your thoughts?
Look, thank you, Dan, and it's an excellent question. And as I say, of all of the things I described, kind of my entry into the digital world is perhaps my most recent, and led by colleagues kind of far more erudite than me in this space. But I absolutely, what you're saying resonates with me really strongly. Alarmed is too strong a word, but I am concerned about the alacrity with which the focus on AI and digital is taken up, not about the enthusiasm around it, but about the assumption that more and deeper and more developed is better. Because I do think what you're saying is right, which is that we haven't adequately scoped, what are the ethical parameters around this? What are some of the areas in which it might be contraindicated or even counterproductive? And so while I have a lot of enthusiasm around it, I guess I manage that issue by treading cautiously in many respects, and focusing, and certainly together, as I say, with my colleague Dr. Olivia Metcalf, we're focusing as much on what does this mean from an ethical and participatory way in every step we're taking, being very conscious around those issues for every step. So probably at the risk of underdoing what could be achieved in what the technology would offer, but balancing out by being a bit more confident that what we're doing is kind of ethically sound. But I can see that the potential for us to do a lot more down the track, but it does get increasingly complex when it comes to where does the data go, what can people know about you, what are the implications of that, and what are the parameters of where is that advice to you coming from, the degree to which that gets digitized and driven by algorithms to the point that we're not confident that what the person's getting is what the most ethical or best practice advice might be. And certainly we're aware of a number of situations in things that we've been looking in the field around us where that's been the case, where people have got very worrying advice from the digital technology that they're interacting with, and concerns about where some of their personal data is going and what can be tracked in relation to their responsivity to situations, and location critically as well, how important that is, particularly if we're talking about violence.
Absolutely. And I think what's unique about you and the work that you undertake is you're not just a researcher, you're a clinician as well. So you actually put this into practice. Some of the anxieties that I have as we move further down in the AI track is how it's used in clinical practice, everyday practice. Do you have any tips for junior medics going through medical school who are being swamped with this sensory overload of all this technology that's going to make the world easier, but actually, is it? What would you give tips to some of those junior medics coming through?
Look, it's a good question again, and it's the same tip that I give myself in many respects, which is kind of choose wisely, choose what's absolutely going to be the best fit for you. You're probably inundated with a multiplicity of options, of technologies, of points of focus, but choosing wisely and choosing it where it actually meets a specific need with a level of confidence in the robustness of the quality of it, but not only of the technology itself, but also the advice and support it's giving you, and your confidence around the parameters of the data management, data control elements of it as well. And I do think that's a bit where, if we're thinking in the future about where are we going, I mean, as a clinician, I've been encouraged by seeing how some of my patients, some of the communities I've worked with have been able to use technology and really is a really valuable adjunct. Let's face it, as a clinician, they'll see me for 1 hour in a week. And there's so much more that needs to happen over the course of the time to help them improve their mental health and well-being. And so the degree to which technology can help as an adjunct, well integrated, well scrutinised by the clinician, where the clinician and the client make judicious choices together about what's the best program for what context, how do you use it, what's the interface between that and what we're doing clinically. And then for that to increasingly get personalised, I think has an increasing potential going forward. But not more is better, more is probably worse. Specific quality is better and not necessarily more or more sophisticated.
And thinking about your roles on the NATO task force panels, especially around precision medicine, and here we're thinking about actual real world implementation. What do you see as actually being implementable within the next 5 years as a tangible tool? Because obviously we talk about research and what's research viable product, but actually what makes it to the real world is two very different things. So with your NATO task force hat on, what do you actually think is implementable as a real world application in the next 5 years?
Look, I still think at the moment we're in somewhat of a discovery phase in relation to what are we, particularly if we think about the front end of the continuum or kind of the upstream prevention space. I think that's probably, in terms of early intervention, and treatment, I'll kind of talk about that secondarily, but in terms of there's so much effort focused on how can we use precision medicine to prevent the development of mental health in people who are exposed to predictable significant adverse events. I think in that space we're still very much in the discovery phase about what are the factors, what are the variables, and I think that within that space what I can see coming within the next 5 years is a more sophisticated integration of varying streams of technology. So where VR technology is going in relation to allowing people to actively rehearse high stress, high threat scenarios that can be manipulated, the level where ambulatory psychophysiological measurement is going in relation to be able to provide real-time feedback as they're engaging in these deep scenarios through the VR, the degree where AI is going in terms of being able to generate predictive heuristics around individual patterns of reactivity or risk, and to have that with an interface with the user so that they can then interact with the insertion then of kind of what best practice advice might be in terms of self-regulation, self-management. Each of these areas is moving in their own right. They're not really moving as much as they could in terms of an integration, but I can see the integration happening within the 5 years such that that actually becomes something from a real world perspective where we do have those in high risk roles doing this routinely as part of their, if it's shown to be preventative and effective, routinely going through this repeated inoculation process that's as close to real life as we can make it. And some of the VR with full multisensory haptics these days are very realistic. And I think the more we can do that, I would see that could be part of training for military, for firefighters, for ambulance workers, and for frontline health workers to some degree as well, exposed to occupational violence.
Thanks, David. I think I've warmed you up suitably now for Martin's deep question.
It's actually going to be less deep than what you've been talking about, so I guess that's a good thing in a way. It's actually kind of related, which is good because it means we're all thinking about the same things. So coming at this as a kind of a non-specialist, and obviously correct this assumption if I'm wrong, but I think there's a body of literature that would suggest that technology, your smartphones, etc., your iPads, there's a risk, particularly I think among young people, of this actually exacerbating mental health conditions. So I wonder, and again, we've kind of touched on this already, I wonder how that sits with this idea that we can deliver mental health interventions using that same technology. I guess, first of all, is that a valid assumption? Is that a valid observation? Is there that tension? And if so, how do we kind of deal with this? And I think we have touched on this a little bit already, but maybe this is kind of taking a bit more of a broader view, if that makes sense. So any insight there would be great.
I suspect Dan might be able to answer this better than I could, but I will have a go.
I'll throw it out to you both, absolutely, yeah.
And my view would be to demarcate in the first instance between what's the value or quality of the digital device or in technology or intervention from the issue, and how can it help, from how can it be misused and what's the broader context in which it might be misused. Because I think there's value in us thinking about those differently. I do think that technology can go a really, really long way to being able to support mental health and wellbeing across the community, generally speaking across the community in terms at a universal level, as well as then at an individual level as people might be in different parts of the continuum of wellbeing. So I think that there is a space. The reality is there's only a small number of mental health professionals, so we need systems that are writ large, that have high reach and expansion to be able to support that. And from what I've, certainly from my exposure to patients, community who have used these devices, many have found benefit in them. There's a bit of proliferation of them, so you've got to be thinking wisely about which you use, but I think it can go a long way. Separate to that is, how does the next generation use technology, the degree to which they give over themselves to it, the degree to which they give over their sense of identity, lose a sense of self-efficacy or personal integrity to it, and then kind of lose a sense of a tangible engagement with life as we know it outside of the technology. So I think that those to some degree are separate issues. They're obviously connected, as you say, Martin, and one can easily slip into the other. But I'd be reluctant to lump them together because I think we run the risk of throwing the baby out with the bathwater if we do that. Issues we've got to deal with in terms of society, how it functions, next generation, although I think it might not be as bad as we think. And secondarily, how can we maximise the value of really powerful digital interventions, both in terms of reach and depth?
I'm just going to add to that some of my thoughts, because there's such an interesting topic. I think with my researcher hat on, it's quite important, and it touched upon, David, what you mentioned earlier around having robust evidence and robust trials. Actually developing efficacy of the interventions is, I think, really key. But secondly, what doesn't happen not often in the literature, and I've been doing this for the last 5 years in reporting our trials with digital technology and mental health, is actually also reporting the adverse events of those trials, and actually being honest, and disclosing in your papers what adverse events occur and collecting them. And many studies at the moment don't report adverse events because it's not a one-size-fits-all model. So how do we get to a point of actually reporting the adverse events, that we can understand them, recognize them, and try and mitigate them for the future? And that that tangentially linked to another question I had for you, David, around more broadly the literature when we talk about terms such as trauma or recovery. Are there any words that are currently used in the literature that you would change if you had the ability to change it? Are they're just terms that you think actually they're not appropriate, but we've just been using them for too long, and actually we need to be thinking around, it's not trauma, it's not recovery, it's actually something else?
Look, that's a really good question. Unfortunately, as you mentioned, my first paper was 1993, which kind of speaks to, maybe I've been involved in this for too long. Our challenge at the time was getting trauma recognised as a real phenomenon, and for its impacts to be recognised. It's proliferated, and it has become a bit of a lay term. So the word trauma and recovery have now taken on meanings that perhaps lose a little bit of its initial intent, which is certain kinds of events that really shake you to your core in relation to threat to life, physical integrity, violation, etc. So I don't know that I'll be changing the word trauma or recovery, but I'm recognising that half the time I see it, I feel a little bit nonplussed in the context in which it's being used. I think a term that I'd like to see us used more, and this is something mentioned, has been spoken about a little bit by Professor Arik Shalep, is the notion of survivorship, which is the reality also is that life can and is often very tough, and sometimes the trauma doesn't stop, and sometimes what we need to be focused on is how we are coping and managing in the context of severe and ongoing adversity. What does that mean to be surviving through really bad times? And what does that mean to be supporting what function looks like over the course of that time? I think we get very symptomatology focused, and we get very recovery focused, exactly as you're saying, but sometimes we need to explicitly also value the notion of how do we help people get through things that could destroy them in more ways than we can count. And what does that look like? And what do we know when they're coping, when they're doing okay? It might be that they're still very distressed, but they're functioning in this role or that role. They're still able to be a father, a mother. They're still able to do the things they need to do to keep them and their family persisting through this adversity. So I think if I was talking about a change in terminology, it'd be more about an addition, and picking up that notion of also a focus on functional survivorship.
But I guess that's quite an interesting. I find that really. I completely agree, but I find it interesting then if we flip it round. What do you do to also maintain your own well-being? Because after a career in trauma, which is incredibly challenging, and you're talking about survivorship, but how do you survive as a researcher and a clinician on the other end, your well-being?
Look, I think at one level, I think the research, combining the research with the clinical work, is very protective, because that allows me to kind of bring that curious scientific mind to everything that's happening as well, which is also somewhat protective in terms of kind of emotionally. I mean, one, obviously we all get trained in how to protect ourselves emotionally as much as possible while still maintaining kind of a strong alliance and engagement with our clients or our patients. But I think the scientific element to it is a bit protective as well, because everything that happens I'm looking at with that lens, and that's a bit one step removed. The other is I have an unhealthy interest in Australian rules football, which keeps me focused on the inane and the ridiculous at the same time, particularly with the awful status of my football club. And so I think that the inane and ridiculous element of that just helps with the counterbalance, really. Yeah.
Brilliant. And final question from me before passing over to Martin, I think to wrap up, is touching about what we started with was the fact that we, within our department and with our faculty, we have early career clinicians, early career researchers who will be listening. What do you think in terms of what skills or mindset do you think will matter over the next decade when we think about trauma?
I think very important is that we don't get stuck in a silo in how we think. I think if we look at the last 20 years in trauma, it started off very expansive and then started to feel like it knew what was going on. And then it's just doubled down on those narrow lanes of thinking. Now, they are different streams, but within each of those streams, there tends to be a progression within those streams. And I think that some really important for trauma going forward is to be able to step back and look at human experience more broadly, the breadth of human experience, and start to think differently about how we approach these psychologically, neurobiologically, pharmacologically, from a holistic perspective, from a meaning perspective, from a community perspective as well. And then the interface with technologies and other advances, engineering, other advances in science outside of our space, where the whole world is kind of shaping up very differently in terms of what we can learn. And then the engagement with those broader disciplines will help the trauma field get out of the narrow lane.
Wonderful. Dan, David, thank you. I feel like we could speak about this for hours. I feel like we've really only scratched the surface. But David, I'm conscious of your time. So as Dan says, maybe I'll just ask one quick final general question and then we can wrap up. One thing I like to ask, so obviously, David, you spent the beginning, was fantastic, giving an overview of what you're interested in, your skills, potentially what you could offer in terms of working with other people. But is there anything, quote unquote, missing from what you do, other skills that might be present in our school, in our department at King's in general that you might be looking for? Maybe I'm getting a sense something around digital health a little bit, maybe on the, I don't know, let us know, and then maybe we can get that two-way kind of collaboration going. So yeah, that would be my
I think absolutely, digital health, public health. I think the interface across those, I think, would be fantastic.
Perfect. Wonderful. Yeah. So if you're listening and you have those skills, I know we've got Dan here as well with those skills, but if there are others listening, reach out to David and hopefully we can get some nice collaborations going. Superb. Dan and David, thank you so much for your time. Again, I feel like we could have spoken for hours and hours, but hopefully this has been a nice overview for people to listen to, and hopefully this can bring forward some collaborations. Either of you anything to add before we close?
Just thank you for the opportunity.
No, thank you so much, David, for your time. It's been fantastic. And then, like I say, hopefully this leads to some great collaborations going forward. Thank you both so much for your time. Thank you.
Thank you.